We are live.
Good evening, everyone. I welcome you all to yet another online iFocus session. Today is 476th lecture number of the iFocus online session. Today we have Dr. Sri Ganesh sir to teach us about planning and execution of retreatment after KLeX procedures. Welcome, sir.
Good evening. Thank you.
We have Dr. Amit Pandey sir to moderate today's class. After finishing his PG from Bombay and Bangalore and finishing his FICO, sir did his fellowship in glaucoma from Shankara Nethralaya, Chennai. Currently, sir is a senior glaucoma and cataract specialist in Medical City and Armed Forces Hospital, Muscat, Oman. He was the first surgeon in India to implant an IST inject, use oculus gonioidae, and to perform live surgery of MIGS. Sir is also the first surgeon in Oman to do Ahmed Cleopat and perform excisional goniotomy with Cahook's dual blade glide. He is a reviewer of Indian Journal of Ophthalmology and has multiple publications and numerous presentations in prestigious national and international journals and conferences. Welcome, sir, and over to you for the introduction of our chairperson, Dr. Rupal ma'am, and our speaker, Dr. Sri Ganesh, sir. Hello. Hello, sir. Are we connected? You're on mute.
Hello. Oh, I was on mute.
Yes. Did you say something?
Sorry, I'll start again. Can you hear me now?
Yes.
Yeah. Good evening, everyone, and I welcome all of you to this iFocus session. It's my absolute pleasure to welcome all of you. We have an insightful discussion ahead, and I'm honored to introduce two stalwarts in the field of refractive surgery who actually need no introduction, but still it's my duty to introduce them. And first we have with us our esteemed chairperson, Dr. Rupal Shah ma'am. Ma'am is a pioneer in refractive surgery, and her work has shaped the field. She continues to inspire ophthalmologists worldwide. She started refractive surgery way back in 1994 when I think most of our listeners would not have been born. Fondly, she is described as the mother of smile. She's the first person in the world to do one incision smile, first in the world to use Circle software in a patient for retreatment in smile. She has trained more than 2,000 ophthalmologists across the world, and she's a pioneer in LASIK, has performed more than 50,000 procedures. Currently, she is the medical director of New Vision Laser Center for Sight in Vadodara in Gujarat. And last month, she conducted the 77th LASIK training course attended by 20 ophthalmologists. And each time, these many ophthalmologists are getting trained. She has many national and international publications and presentations, numerous chapters, prefaces, and introductions in several prestigious international books. She's the recipient of numerous awards and gold medals. And if we start describing all of them, I think the session will be over. And again, it's my absolute pleasure and honor to introduce Dr. Sri Ganesh sir. He's the chairman and managing director, Nethradhama Super Specialty Eye Hospital, the first eye hospital in the country to get an NABH quality accreditation. He's the secretary of International Intraocular Club and treasurer of the APA-CRS. He's a cataract refractive surgeon who has been in the forefront for newer technologies in phaco and refractive surgeries. He has more than 100 publications in peer-reviewed journals, has performed over 200 live surgical demonstrations, and has presented multiple papers in national and international conferences. Yeah, amongst a few of his awards is the Colonel Rangachari Award for Best Free Paper in AIOC, the AUSCRS Gold Medal Oration Award from Dr. Graham Barrett, Michael Kritzinger Award by International Society for Refractive Surgery at AAO. I welcome both of you, and with our chairperson's permission, I would hand over the session, and I'll invite Dr. Sri Ganesh sir to take it forward. Thank you so
Thank you,
much.
Dr. Amit, for a generous introduction for both of us, and also for making me feel ancient. Thank you. And we're really looking forward, Sri, for your lecture.
Good evening, everybody. Good evening, Dr. Rupal. She's not the mother, she's the godmother of KLeX and Smile, because she actually started Smile and was one of the pioneers. And then Dr. Amit Pandey, a young surgeon here, and all my young colleagues, it's my pleasure to talk about KLeX and enhancement techniques after KLeX. Let me start sharing my slides now. Yeah, is it visible now? Is my presentation visible on the
Yes,
screen?
sir.
Yes,
Okay.
sir.
So let's look at enhancement techniques following KLeX. Of course, now the word KLeX has come in, keratolenticular extraction, because there are various companies which have their own names. Smile basically from Zeiss, Smile and Smile Pro. And then you have the Smart Sight from with Atos from Schwind, and then you have the Clear from Zima, and you have Silk on the Elita from Johnson & Johnson. So there are like 4 companies which are offering lenticular extraction now. And there is a lot of confusion among what terminology is to be used. We used to say Smile initially because that was the only machine available, the Visamax. But now with 4 machines available, then there was a consensus by refractive surgeons to have a common name for this procedure, and hence the name KLeX came about, which is keratolenticular extraction. And so now let us look at post-op. If there is residual errors and patient dissatisfaction, how do you actually manage that? I am a consultant for Carl Zeiss, Meditech, and Biotech Vision. Okay, the slide is not moving. Okay, good. So when it comes to residual errors after KLeX, there can be either an undercorrection or an overcorrection. How do I want to minimize that? Yeah, let me just get the. Okay, so there can be undercorrection or overcorrection. So why do you have undercorrection after lenticular extraction? One is improper refraction. If you're not refracted the patient properly, then you can have undercorrection. So it's very important to do a proper refraction, and the refraction protocol has to be defined. Most hospitals, most clinics, they refract to 6/6. But ideally, you have to refract to the best corrected vision and within 0.25. This is very important for good post-op results and also to develop your nomograms. If you do not refract the patient properly pre-op and post-op, you will not have proper data. So having a chart standardized, ATDRS chart at the correct distance, doing a proper refraction, refining the subjective manifest refraction to get the best corrected vision within 0.25 diopters is very important. Then the other reason why you can have an undercorrection is contact lens warpage. So patients who are wearing contact lenses, especially rigid gas permeable contact lenses, have to stop contact lenses at least for 2 to 3 weeks. Sometimes 2-3 weeks also may not be adequate. You have to do repeat topography to see that the topography becomes normal. Otherwise, you can have either an undercorrection or overcorrection depending upon the fit of the contact lens. If you have a steep fit, then you have like epithelial heaping in the center, which if you do an epithelial map, you can see that. And then you correct the patient for that refraction, and then you will have an undercorrection. So it's very important that you stop contact lens, especially RGP lenses, for at least 2 to 3 weeks, repeat topography and see that the topography is normal. The other reason you can have a residual refraction after KLeX is corneal hydration. Sometimes you're put in the speculum and then your assistant is just putting in saline over the cornea because it's getting delayed. The cornea can get hydrated. When the cornea swells and you do the KLeX procedure, then you're going to, there's a relatively thicker cornea. And then when you actually do the lenticule extraction and then the corneal thickness reduces, you can have an undercorrection. This is one of the rare reasons, but you should be aware of about it. The other reason is poor suction. So again, if the suction is not adequate, then it can be for various reasons. Either you're not put in the tubing properly, or there's some leak in the tubing, then you have a poor suction. Then the eye is not held properly, and then your lenticule creation also, the plane can shift a little, and then you can have an undercorrection. It's again a rare reason. Overcorrection can happen because, again, improper refraction. Many of the young myopes have spasm of accommodation. And if you're using an autorefractometer, typically you get higher readings. And then if you take these readings without doing a cycloplegic refraction, then you can have an overcorrection and residual hyperopia. Again, contact lens warpage can also be one of the reasons for overcorrection. Corneal dehydration. Okay, this is a very important reason why you can have overcorrection. If you have corneal drying and the corneal thickness reduces, this happens if you have actually put in the speculum and then you're waiting for some time, and then the cornea dehydrates, the corneal thickness reduces, and then you do the lenticule extraction, and then what happens is, then the cornea expands. So the amount of tissue which you have removed is relatively more, and then you can get an overcorrection. I had a colleague doing SMILE, and he said he was complaining that he was getting overcorrection. And then he was not able to figure out why he was getting overcorrection. His refraction was okay. But then, I asked him where is the air conditioner placed, and he said, we have a split AC, and the draft was blowing on the eye. So the cornea was getting dehydrated. And when the cornea gets dehydrated and you do a lenticule extraction, you typically get a overcorrection because you're removing more tissue in the compact cornea than is required. It's also very important to have a nomogram, and every practice, every surgeon, depending upon how he refracts, should have a nomogram. Otherwise, you can have typically undercorrection with lenticule extraction procedures. So we have a nomogram of about 10% overcorrection for myopia, for the sphere, and 15% for with the rule astigmatism. Most of the myopes have with the rule astigmatism. Because again, when you're doing the refraction, you need to kind of overplus when you're doing the refraction so that you give the minimum minus power for the patient to achieve best corrected vision. There are some practices which actually kind of don't do this fogging or minimal minus or overplussing during refraction, and then for them the nomograms will be different. So if you do a standardized refraction, minimum minus to be given. That means you're overplacing when you're doing the refraction. Then you can have nomograms. Also, post-op, it is very important to do a manifest refraction. Correct subjective manifest refraction. Most surgeons will do a binocular vision. If the patient is reading 6/6, they say, oh, correction is perfect, everything is fine, and then they send them home because they don't want to do a subjective refraction. They don't want to put lenses in front of the eye, because if there is a residue of even minus 0.25 or so, then the patient will be upset and say that he's not had a full correction. So it's very important while counseling patients for refractive surgery that you tell them that this is a procedure where you will reduce your dependence on glasses. You cannot have like a 0 post-op. It can be like plus or minus 0.5 the accuracy, because healing is something that we cannot control. And this is what I tell my patients. And I tell them that we will do a refraction so that we know what we have achieved. But what is important is not the refraction, it's your vision. So if you have 20/20 or 20/25, then you can do all your normal activities without any glasses. So even 6/6 parts, 6/9 vision or better, you can even get a driving license without glasses, and this is adequate for all your normal activities. So don't promise 0 correction. And post-op, always do a refraction, check for the best corrected vision, and refract up to 0.25. So you will know the exact. See, a patient may be reading 6/6, but maybe with a minus 0.25 and a minus 0.5 cylinder, he may be improving to 6/3. So his best corrected vision is 6/3, and his residue is like 0.25 with 0.5. Okay. But you need not give him the prescription, but you will know what you are getting post-op. And this is important for nomogram development. And once you develop your nomogram, then you will have a very good post-op outcomes. The chances of having a residual error will be less. So these are things that you need to take care of. You need to do a proper standardized refraction. You need to develop your nomograms. If the patient is wearing contact lenses, you'll have to ask them to stop for soft contact lenses at least a week. Semi-soft lenses, 2 to 3 weeks. Repeat topography, see that the topography is normal. Intraop surgical technique also is very important. Avoid dehydrating or overhydrating the cornea and see that suction is adequate. So if you follow all this, then I think the chances of residual error after KLeX will be minimal. In our series, we have submitted our first 1,500 eyes with the Visumax 800, and we have 99% of patients within half a diopter spherical equivalent, and 98% 6/6 or better vision. So you can achieve these results if you take care of all these factors pre-op, and then your chances for enhancement will be very low, your incidence of enhancement. For us, now I've almost done about 20,000 smiles, lenticule extractions with the 500, the 800, and also we use the Zima system, and then our enhancement rates are very low. Out of 20,000, we may have probably enhanced about 20 eyes, which is like about 0.1%. Typically with LASIK, it can be 2 to 3% enhancement rates. With SMILE, published enhancement rates are like about 0.4, 0.3, 0.4. In our practice, it's like 0.1 to 0.2%, which is extremely low. So if you take care of all these things, then your enhancement rates will be low. Okay. Now, coming to the residual error after KLeX, you can have either, why do you have a residual error after KLeX? You can either have a progression or a regression. A progression of myopia can happen in young patients. And this is something that you have to warn them, because today, most of the patients are fixated on their digital devices, either laptops, iPads, or their phones. And then if they are continuously looking at screens for long periods of time, even in age groups of 30 plus, even 40, I have seen progression of myopia. So this is something that can happen. So it's very important that you warn them about this, ask them to take frequent breaks, the 20-20-20 rule. So every 20 minutes, just look away from the screen for about 20 seconds at a distance of 20 feet. And this will actually kind of reduce the chance of progression, because most of these people who come in are IT people who are working like 8 to 10 hours, even 14 hours on the system. Then the other reason for progression of myopia, where actually the axial length increases. So whatever correction you have done on the cornea is fine. The keratometry is stable, but there is an increase in the axial length. The increase in axial length gives rise to a residual refractive error. So pregnancy and lactation is another condition where you can have hormonal changes and you can have progression of myopia. And this is what we see, like about 5% of women can have this during pregnancy, progression. So when a patient comes and asks you, doctor, is this a permanent correction? Then you tell them that, yes, it is permanent. What we do on the cornea is a permanent correction, but there are chances that your myopia itself can progress. Okay, and these are the conditions. The other condition is hormone replacement therapy. Many of them, especially younger girls, have PCOD and they are on hormone therapy. So sometimes patients on hormone therapy can also have progression of myopia, and this is something that you need to warn them. Severe viral infections, debilitating viral infections can also lead to progression of myopia. And also malnutrition. If there is malnutrition, deficiency, vitamin B12, vitamin D deficiency, most of these patients are not getting adequate sunlight. They have vitamin D deficiency, and this also can lead to progression of myopia. So it's very important that you understand that there can be progression and explain this to the patient. And in our practice, we always check the axial length. When we are doing the topography, pre-op, we also check the axial length, record the axial length. So post-op, if there is some residual error, if you repeat the axial length, then you will know if the axial length has increased, that it's a progression. Okay, that's how you know that it's a progression. So always measure axial length in all your refractive surgery patients, because you can tell them, see, the length of your eyeball has increased. That's why you have a residual power. The correction that we have done on the cornea is fine. There is no change. So always it is the problem with the patient. So then you have regression. Now, regression is when there can be a residual refractive error because of healing. So what are the reasons why you have regression? So here the axial length is stable. Regression typically happens within the first year. By about 2 to 3 months, you will have regression. Okay, this is because of the healing. When the healing is happening in the first, say, 3 to 6 months, then you can have some amount of residual error. And this is known as regression, which is different from progression of the refractive error or the myopia. So small optical zones, if you're using smaller optical zones, then you can have regression. This is more so with excimer lasers than with lenticule extraction, because in lenticule extraction, you don't have what is known as the cosine effect. I will explain this later on. But even in KLeX, we try to keep a minimal optical zone of about 6 millimeters. 6 millimeters, you can, between 6 to 6.5 is ideal. Indian eyes, Caucasian eyes, which larger pupils, you can go up to 7 millimeters. The maximum I think that the machine allows is like 8 millimeters, but don't go in for larger zones because you will be removing a lot of tissue, which is again not healthy for the cornea in the long run. So you can assess and look at the pupil size also, and depend upon, then decide on the optical zone. The other reason why you can have regression is transition zones. Now, transition zones are very important for LASIK, because if you have an excimer ablation without a transition zone, then you can have a higher risk of regression. Whereas with lenticule extraction, typically you don't have much of transition zone. You can, with SMILE, there are no transition zone. If there is a cylinder, then you have a transition zone of 0.1 millimeter only. So because again, there is a clear excision of the tissue, there is no fluence loss in the periphery. So you don't need much of transition zone with lenticule extraction. The other reason why you can have regression is corneal biomechanics. especially in younger patients, if you have weaker corneal biomechanics, then this can affect the long-term stability of the cornea. So corneal biomechanics is not only about, ectasia and developing ectasia, because when you say corneal biomechanics, you're checking for keratoconus or chances that the patient can develop ectasia. But corneal biomechanics is also important for stability of your correction which you have done. This is actually very important for hyperopia also. When you are treating hyperopia in younger patients, corneal biomechanics plays a huge role in regression. So that's why there are some studies. Pavel Strudelka has done a nice study where he does cross-linking LASIK extra for hyperopia, and this kind of improves the corneal biomechanics, and he finds that regression was less. Epithelial hypertrophy is another reason why you can have regression. And with myopic KLeX, you're flattening the center when you're treating very high myopia and the central zone becomes very flat. Then there is a natural tendency for the epithelium to thicken in the center, and this can give rise to some amount of regression. We also did a study on epithelial changes after SMILE, and it's published in the JRS. I'll speak about it. In hyperopia, if you're doing KLeX for hyperopia, then you have, again, regression because of epithelial hypertrophy. Using larger zones, this can be reduced, but still you can see that you're creating an abnormal shape in the cornea. You're creating a donut kind of a shape of the lenticule, and you're removing more tissue in the mid-periphery, and this gets filled up with epithelium, and then you have regression. So these are the reasons for progression, regression, and residual refractive error. This is one of the studies which we did where we looked at corneal flattening between SMILE and femtoLASIK in relation to the optical zone. And we did differential keratometry topography maps, tangential maps, pre and 3 months. Post-op scans were compared to the optical zones. We matched the optical zones for both LASIK and SMILE. And what we found that compared to the optical zone, SMILE had a significant wider zone of flattening post-op versus femtoLASIK for the same optical zone which is set. So zone of flattening on an average with differential tangential maps, what we found with femtoLASIK was 69% as compared to SMILE, which is 80%. This is because with an excimer laser, as the laser fires in the periphery, you have some amount of fluence projection loss. So again, with waveframe to optimize LASIK, they give extra spots in the periphery to counter that. But even with that, you still have a smaller effective optical zone when compared to SMILE. So again, if you have a smaller optical zone, effective optical zone, then regression can be higher. So typically with LASIK, we like to keep 6.3 to 6.5 mm zones as compared to SMILE, where 6 mm zone also is fairly stable. Now, if you look at the stability of SMILE, this is what I was saying, when you compare it to LASIK, if you look at the stability of SMILE, there was a long-term, a paper with long-term results, 10-year results with SMILE, published by Walter Suchendo and Marcus Blum. And they found that they looked at the first 91 eyes which were treated with SMILE. These were like more than 10 years ago. This was published in 2019. So out of the 91 eyes, they were able to kind of follow up 56 eyes over 10 years. And they found that the spherical equivalent, post-op spherical equivalent was minus 0.35 diopters, very close to the target refraction. And they also found that 56 eyes, 29% had gained 1 or 2 Snellen lines, and there were no loss. So the regression was on an average minus 0.35 plus or minus 0.66 diopters over a 10-year period. So with lenticule extraction, the correction is very stable. Regression is minimal, okay, as compared to LASIK, the long-term stability. This is probably because of better biomechanics, larger optical zones, and lesser epithelial changes. So all these three things will give rise to a better stability of power over a period of time, and this is actually published data. The other platforms, of course, you don't have long-term data, so that's why we are looking at SMILE. We also published a paper on in the JRS on epithelial thickness profile changes following SMILE for myopia and myopic astigmatism, and we looked at 3 groups. We had a total of 100 eyes and 3 groups, 38 eyes for low myopia, spherical equivalent of less than 4 diopters, 44 eyes for moderate, -4 to -6, and 18 eyes for high, that is more than 6 diopters, up to 10 diopters of myopia. Okay. And the average optical zone was about 6.5 millimeters. At 3 months, we looked at the epithelial thickness changes, and there was an increase of about 6.80% for low, 9.26 for moderate, and 12.7% for high myopia. Okay, and even between different areas, there was a different percentage of thickening of the epithelium. But what we found that 4 eyes of 2 patients with high myopia, where the spherical equivalent was more than -8, they had regression due to significant epithelial thickening. So epithelial thickening with very high myopia can lead to some amount of regression and residual power after KLeX procedures. Now, let's go on to enhancement techniques after SMILE for residual refractive error. So SMILE has been done or KLeX has been done, and then the patient comes back, has a residual refractive error, and doesn't want to wear glasses. So how do you treat it? These are the various techniques which you can use to treat residual refractive error. So the first is the surface ablation. Surface ablation, of course, I'll go one by one, but I'll just mention the various techniques. Surface ablation or PRK or advanced surface ablation can be used. Then you have what is known as the thin flap LASIK, where you can make a thin flap in the cap of the SMILE patient. Then there is another technique where you can make a side cut to convert the cap into a flap. So you can program just the side cut using the flap software in some of the machines. So most of the machines, like with the Clear from Zimmer and Silk, you can do this. I'm not sure about the ATOS, but it should be possible. Zeiss has a very special software called the Circle software, which actually converts the cap into a flap, so you can lift the flap and do a LASIK, an excimer laser ablation. Then you also have the technique of what is known as subcap lenticule extraction or re-SMILE, or SMILE on SMILE, where you can again redo a SMILE for the patient. And of course, the last option, if the corneal thickness is not adequate or you have some abnormality in the topography, maybe a decentered ablation, then you can treat this with a phakic IOL. So now let's look at PRK after SMILE. This is the simplest procedure to perform, and it's ideal for low enhancement. Suppose you have like a 0.75, then you can do the PRK. The epithelial thickness has to be taken into consideration if you're doing trans PRK. If you're removing the epithelium with alcohol or mechanical debridement, it's not a problem. If you're doing trans PRK, like I showed you in the previous paper, you can have a change in the epithelium. So most of the machines for trans PRK, they take a standard 55 microns of epithelial thickness in the center and about 60 microns in the periphery. But this will not work because you have epithelial thickening. Sometimes you can have up till 80 microns of epithelium in the center, and this has to be taken into consideration. Otherwise, you will get undercorrection with trans PRK. and use larger optical zones with trans-PRK. Then it's very important to also use mitomycin C, 0.02%. Typically for PRK, you use it for about 20 to 30 seconds. But after SMILE, after any lenticule procedure, or if you have any interface, whether it is LASIK, lenticule, or even corneal lamellar surgeries like DALC, then you have to use mitomycin C for about a minute, because you have a higher incidence of haze after lamellar surgery. If you do surface ablation after lamellar surgery, because the keratocyte activation is much higher. So you need to use mitomycin C for 1 minute. There is also an increased risk of haze with PRK after SMILE, and this is a picture of haze. So you can have this haze. You can either have a central or a mid-peripheral haze like this, and this can reduce over a period of time, or it can lead to scarring and loss of best-corrected vision. So this is the disadvantage of PRK. And the predictability of PRK also is not as good as doing a thin flap LASIK or the circle software. But the advantage of PRK after SMILE is that you maintain a flapless procedure because you have promised the patient a flapless procedure. This is a paper by Walter Sukendo on enhancement after SMILE, myopic SMILE, using surface ablation. And they concluded that combined with intraoperative application of mitomycin C, surface ablation seems to be a safe and effective method of secondary enhancement after SMILE. Okay. And they use the MEL90 here. They use the ASA profile. No, they did not, because of the low residual myopia, the ASA profile is not recommended in these cases. So you can use right now with the MEL90 or the AAA profile. So you can use that, or with any other laser that does surface ablation. You can do the surface ablation, but use mitomycin C. And like I said, if you're doing trans-PRK, then epithelial thickness has to be taken into consideration. That's about PRK. Now let us look at LASIK after SMILE. So you can do a thin flap LASIK after SMILE if your cap thickness was 135 microns or more. And this is what is promoted by Dan Reinstein in London Vision Clinic, where regularly they keep a 135 micron cap. The recommendation by Zeiss and other companies is like a 120 micron or a 110 micron flap. But if you have a 135 micron flap, then you can do an enhancement with LASIK. This is ideal for, again, low enhancements. Again, you have to take in the epithelial thickness while planning the flap thickness, because if you're planning a 100 micron or a 90 micron SBK, okay, and your epithelial thickness is like 70 or 80 microns, then you can have buttonholing, you can have, there's hardly any stroma there, the chances of flap slippage, micro wrinkles are much more. So it's very important to look at the epithelial thickness, do an epithelial map, then decide on what thickness. So ideally you use a thickness of 100 to 110 microns. And then if you use a thicker flap, then there is a risk of entering the previous interface, and then you can have problems. Also, you have to plan the hinge away from the SMILE axis incision. So normally if the SMILE axis incision is at 12 o'clock, then you use a nasal hinge so that you don't actually overlap on the SMILE axis incision. So this was the paper by Dan Reinstein et al. From London Vision Clinic, where they used thin flap. They did a retrospective review of eyes that had undergone retreatment by LASIK after primary SMILE. And they did a total of 116 LASIK retreatments out of 2,643 SMILE procedures. And they concluded that retreatment after SMILE by LASIK, that is thin flap LASIK, achieved excellent visual and refractive outcomes. Although these results indicate that myopic LASIK retreatment after primary myopic smile requires a different nomogram than for myopic LASIK in retreatment after primary myopic LASIK. So if you're kind of retreating a post-LASIK patient, it is different from the nomogram when you're treating a post-smile patient with a thin flap. So that is what they concluded. But this technique can be used doing a thin flap LASIK, and it is quite easy to perform. But the original cap should be 135 or more. Then comes the Circle software. This is a software that was first used by Dr. Rupal Shah also. And this is a very unique software which is available only on the VisuMax. It's not available with the other KLeX platforms. And this is the enhancement solution for smile. It allows the surgeon to convert a cap into a flap. And basically, this is the configuration of the incisions. You have a lamellar ring which is there. And then you have a side cut with a hinge. Okay, this is how you access and lift the flap. And then you have the junction cut from the inner edge of the lamellar ring to the junction depths. So you can set this so that you enter into the original interface of the smile. And the advantage of the Circle software is that you get a larger flap. Now you can, like I said previously, you can also program a side cut. But suppose you have used a 6 mm the optical zone for KLeX, then the outer diameter of the cap would be about 7.5 mm. Okay, so if you program a side cut, it has to be less than 7.5 mm. So maybe like about 7.2 mm or so. And you end up with a bed which is actually quite small, like 7 millimeters or so, on which you can do the treatment. It is okay if you're doing a myopic enhancement. But if you're doing a hyperopic enhancement, you have a overcorrection, you want to do a hyperopic enhancement, then it is not adequate. Because for hyperopic corrections, you'll be using a 6.5 or 7 millimeter zone, and then you have the transition zone. So when you use the Circle software, you get a much larger bed which you can treat. So it's ideal if you're doing a hyperopic correction to use the Circle software. There are different patterns for Circle treatment, and then these are the various patterns, A, B, C, D. So how the lamellar cut, the axis, and the junction is planned. So these are the different configuration. What we normally use is the D pattern now. So this is how a video of the Circle software. So that is the lamellar cut, and that's the axis cut, and then the junction cut. So you put off the suction, and then you can very easily lift the, you delineate the flap, and then you enter into the original interface. So the thickness, you will have to know what was the previous thickness of the cap use. Suppose it's a 120, then you have to put in the details that it's a 120 cap. And then you'll have to configure the pattern so that you enter the original interface, and then you can lift the flap. Once you lift the flap, you can see this is the junction cut. Okay, this is the flap, this is the junction cut, this is the lamellar ring, and then you can do the excimer ablation and you put back the flap. This was a paper by Etek Chansui from Thailand, where they looked at the safety and efficacy of the VisuMax Circle pattern for flap creation and enhancement. And they concluded that the initial series, where they did about 28 eyes, demonstrated that it is very efficacious and suitable method to create a corneal flap for enhancement in post-smile cases. And we have also had good results with the Circle software, and this is what we use regularly now, the Circle software, because we either have a 110 or 120 cap. So for this, you can't do a thin flap LASIK. And the Circle software is excellent, and we have done a few cases. We must have enhanced about 20 eyes. Only a couple of eyes we have done. We did PRK, but PRK again, the recovery is longer. There's pain, discomfort, and the predictability is not as good. So we prefer to use the Circle software. This was another paper by Jod Mehta and Donald Tan, where they looked at the 4 different patterns which I showed you. But this study was done on rabbits, and they concluded that pattern D, lamellar ring adjacent to the cap cut, was the most optimal to be used for flap creation in cases of smile retreatment. But this study was done on rabbits, where they used the 4 different patterns and then looked at how easy it was to lift the flap, enter into the interface. Now, coming to smile on smile, this is again a few of the surgeons are doing it, and it can be done. The Zeiss does not have a software for this, so there is a technique that has to be used, and I will just go through it. I've done only a couple of cases. It can be done if the previous cap thickness is known. So either you get the PDF of the treatment, which was done previously, or you can measure the cap thickness on OCT. And this is ideal if you are treating higher refractive errors. So suppose you have like a -1 or -2 that you need to enhance, then you can do the smile on smile. If you just have like a 0.5 or 0.75 to be enhanced, then it may not be ideal because the lenticule will be very thin. So even here, the epithelial thickness has to be taken into consideration, because when you have epithelial thickening, then again, the level of creating the next, creating the refractive cut again can vary, and you can have changes in the thickness of the lenticule. So if you have used a 120 micron cap and you have an epithelial thickness of 80 microns, then when you're programming it, then you will, and the refractive cut will come up if you enter it as 120. And then you will have a much thinner lenticule and you will have undercorrection. So it's very important to take the epithelial thickness into consideration. The advantage is you maintain a flapless procedure. So you have done smile and you do an enhancement with smile. So how it is done is, after the refractive cut, you program it, you put in the cap thickness, which is known previously, say 120 microns, and the refraction for the power. But what you have to do is you have to increase the minimal thickness to about 30 microns. You can do that only with the Visumax. You can't do it with the other machines. Because what happens is, if you're treating a -1, then your lenticule thickness would probably, using a 6.5 mm zone, it'll just be about 15 microns, 15 to 18 microns, and that is too thin. So you can add the minimal thickness of about 30 microns, so that you get almost like a 48, 50 micron thick lenticule, which is easier to remove. Okay, so the procedure is, after the refractive cut and the side cut is done, because as you know, with the smile procedure especially, first the refractive cut is done, and then the side cut, and then the cap cut. So after the refractive cut and side cut is done, then the suction is put off. You put off the suction, then you open up the original access incision, and you can enter the old interface. The old interface is the superficial plane, so that can be easily opened up. You don't have to dissect it. The deeper plane has to be dissected carefully, and then the lenticule is extracted. Like I said, minimum thickness of the lenticule should be maintained for easy extraction. You can bump it up to 13 microns. And residual stromal thickness, again, you will have to calculate it, and it has to be adequate for the procedure. Ideally, 280 to 300 microns is what we aim for. Centration is critical. So it's very important to exactly center on the previous lenticule, which has been removed, and you can actually reduce the optic zone. So previously, if the optic zone was about 6.5, then you can use a 6.3, because even if there's a slight decentration 200 microns or so, you will still be able to you'll be in that zone where you access um, the superficial plane, which is the interface. This is an off-label use, not approved by FDA, not approved even by Zeiss. This is one of the cases which I did. So you can see the topography. This was a patient whom we did a monovision. See, I was a high myo. We did a monovision correction. We undercorrected the left eye, which is the non-dominant eye, by 1.5 diopters. And but she was not accepting this. She was very unhappy. She wanted a full correction. So we went in and did a smile on smile. So you can see here, this is a flattening, and this is after the enhancement. You can see that the flattening is more here. There's a blue zone. So let us look at the surgery here. You can see that the refractive cut is done, and then the side cut. After that, we put off the suction, and then you enter into the original access plane and then the deeper plane. You don't have to dissect the superficial plane because that is the interface. Dissect the deeper plane. You can see the side cut is being dissected. Once you dissect the deeper plane, then you can very easily remove this lenticule. And this patient had a good correction. So these are the points. If you take care of all this, because you can get a fairly good correction if there is a higher residual refractive error. So this technique was first described by David Donate, and this is a publication in the JRS where they reported the first case of subcap lenticule extraction as a feasible technique for enhancement with SMILE. And this is one case which they reported, and the technique. Dr. Sedki from Egypt also has done some work and on this subcap lenticule extraction. And this is a paper by George Mehta where he looked at again, subcap lenticule extraction, but in rabbits. And they also found that this can be done, but it may be, they looked at different techniques, a circle followed by excimer ablation, and then secondary SMILE anterior to the primary SMILE, surface ablation, etc. And then, of course, but this was again on rabbits, and then they looked at the various techniques of enhancement, and they said that the flapless surgery also can be done, that is the smile on smile. So this is basically the end of my talk, and these are the various techniques for enhancement. I would also like to announce that we are conducting a course with London Vision Clinic, Professor Dan Reinstein, which will be a complete refractive surgery course. It's called Forefront Refractive Surgery, which will cover LASIK, PRK, presbyopia correction, presbyon, SMILE, and phakic IOLs. So we will have didactics, we will have wet labs, and we'll have hands-on surgery. So you can register for the course. There are limited seats for hands-on surgery. It's a very popular course run by London Vision Clinic, and Nethradhama also has a refractive course. For the first time, we are combining and then conducting this course in September. So I encourage all of you all to kind of look at this, register, come and attend the course. It will be very useful. Thank you very much for your attention. And if there are any questions, I would be happy to take them.
Thank you, heartfelt thank you to our speaker, Shri Ganesh sir, for sharing his expertise, such clarity and depth. Definitely, this enhances our understanding of retreatment after KLeX, and also a lot of practical points that we can incorporate in our clinical practice. I would now like our chairperson to give her comments and share her vast experience on this topic, ma'am.
See, as expected, it was really concise and very, very useful. it also, I like the way you started from how to prevent having retreatments, and then went on to if it happens, the causes as well as what can be done. So retreatment in a KLeX procedure is not a very difficult thing, so you should not be afraid. I see that many people who don't do KLeX, they put down the procedure saying no chance of doing retreatments. But actually, as you pointed out, the need to do retreatments are very few. And then you do have alternatives to do retreatment. So I just want to ask you, Sri, apart from the retreatment part, what do you think, where does KLeX stand today? So, and in near future, you think they will replace the excimer lasers?
I think it has replaced excimer lasers to a large extent in my practice. Almost, I would say, 80% of my practice is now KLeX. I hardly use the excimer laser to treat myopia. Of course, for hyperopia, I still use the excimer laser. We are getting the software for hyperopia shortly. Again, KLeX procedures are not ideal for patients, older patients, over 40 years. So for these patients, I like to do Presbyon, and I use the excimer laser, because if you do KLeX, I've done monovision KLeX also, but the visual recovery in older patients is slower when compared to younger patients. This is because of the corneal biomechanics and the natural cross-linking that happens. So for older patients above 40 years, I still prefer the excimer laser, and I do Presbyon. But in all the younger patients, I've completely converted. Now it's 13 years since I started Smile KLeX. So I am quite senior, but not as senior as you in the procedure.
But I've learned a lot from you. Shri, I just wanted to also point out that in corneas which have dense corneal opacity, which are superficial, which are going to come in the way of your lenticule formation, probably are the contraindications for doing KLeX procedure. I had one case today where I did one eye smile and the other eye had a small opacity, but very dense, superficial, and it was going to be in the lenticule, even though it was not exactly in the center, but peripupillary. So I had to do microkeratome LASIK and not even a femto LASIK for her, because I wanted to avoid any complications of flap formation. So
Typically,
that's
these
one point where I think we can avoid doing a femto procedure.
These typically are patients, contact lens wearers who have had infections. So
Yes,
you get
she
these
was one of
corneal
them.
scars. Yeah. So
Yes.
corneal scars, again, it depends upon the density of the scar.
Yes,
If
it
it's
was
just
very
like a
dense.
nebula
It was
grade,
small but dense.
yeah. If it's
So
like a macular grade, then you can't use the femto, because even for
yes,
LASIK, if you use a femto flap, you'll have a vertical breakthrough, and you'll
exactly.
have like a hole there with a vertical breakthrough, which is again difficult to manage. You'll have again risk of epithelial ingrowth and all these problems. So it's best to use a microkeratome in these cases. Sometimes I've had a case with a slightly deeper nebular grade opacity. And then I actually did an OCT and it was below 100 microns. So I
Yes,
actually included this in the lenticule.
exactly.
And I was able to do the lenticule extraction because it was nebular grade. It was very thin. You may have a little more resistance when you're dissecting. You can up the
But
energy
you
a little,
can
but
go ahead and do
you
it.
can go ahead and then do it. It's not that you can't do it for nebular grade, but macular grade opacity is definitely no.
So I think KLeX is here to stay. And the more people start adapting it earlier, it would be better. Now there
Yes.
are also multiple platforms available, so you're not at the mercy of only one particular machine or one particular company. And it is fast gaining a lot of popularity, both in doctors as well as patients. And so I'm sure that we all will need to incorporate this in our armamentarium.
It is the fastest
Learn more
growing.
and more from people like you, Sri.
It's the fastest growing refractive procedure in the world today. If you look at,
Yes.
because LASIK, femto LASIK is degrowing, And Smile, now if you look at Smile, they've done 10 million eyes. Of course, the other platforms are still evolving. The numbers are not that high, but then you have option of 4 platforms now, and
Exactly.
the very fact that companies are investing in kind of bringing lenticule extraction into the market on their machines, so that it's going to be very popular, and this is going to actually kind of replace most of the excimer technologies. For the patient, it is wonderful because it's a painless procedure. Recovery is fast. They have no restrictions compared to PRK or
And
LASIK.
follow-up is
So
much less. So it
follow-up
really
is less,
helps them.
and the long-term paper by Walter Sukendo, you can see that there's hardly any regression because the corneal
Exactly.
biomechanics are better, epithelial healing also. So these are all reasons that it's becoming more and more popular. And I'm sure everybody at some time will have to learn about this and adapt this technology, because your patients are going to come and ask for it. Plus, they should know how to manage problems like
Yes.
enhancement. So that's why today's talk.
Exactly. But having said that, in a country like India, I think even techniques like surface ablation and microkeratome is still here for a while because
Yeah.
of the cost factor. So the moment lasers start becoming more affordable, and the main cost of a fixed cost of the contact glass or the licenses has come down for everybody to adapt it.
True.
What has happened is there is an increase in the affordability. So you can see that the affordable population have increased, and then patients are coming and asking for procedures which actually cost more. So, I mean, even if you look at eye stents, we are still able, though the cost is so high, we are still able to do quite a few of them. So
Exactly.
patient affordability has increased. Even for Smile, the affordability has increased. So overall, I think because of the increase in affordability, you can do more of these procedures. Of course, surface
Yeah, it's
ablation.
also a change which is similar to RK. From RK, we moved on to excimer laser. It was the same difference because
Yes, I
RK people
remember.
were doing even for 5,000 rupees for both
I
eyes.
started my refractive career with RK in '94, and I was doing RK for 5,000 rupees. Mini
Yeah,
RK with the
exactly.
Duotrack plate. Yes.
And yet people did accept lasers because they were giving better results. So I'm
Yes.
sure that lenticular extraction procedures will definitely have more and more acceptance all over.
Right.
Thank you
Thank
very
you,
much. Hey,
ma'am.
this was wonderful.
Thank you.
I have a few questions. So correctly started his presentation by saying how to minimize the chances, like ma'am also pointed out, how to decrease the chances of over or under correction. So would you just give us a basic guideline on how to make a nomogram for the refractive surgeons who are just starting?
Like I said, refraction is very important. So you have to standardize your refraction. Otherwise, it's garbage in, garbage out. So you need to standardize your refraction, have standard charts, ETDRS charts. The distance has to be standardized. The lighting has to be standardized. And then you refract to best corrected vision. Don't refract to 6x6.
Yes.
Refract to best corrected vision. It can be 6:3 also. And refract to within 0.25 diopters. You can use the astigmatic fan. You can use Jackson's cross cylinder. You can use the duochrome test. But try to get as accurate a refraction as possible. And also kind of um, do some overplacing so that you give the minimum amount of power, because myopes, they may accept 0.5 more or even 0.75 more. They say it's sharper, okay, because there is a image minification, the contrast increases. They say, okay, this is better, but you should be very careful not to over minus the patient. So always over plus and give them the minimum minus. And you have the standardized technique of refraction, and then you input it, do 50 or 100 eyes, do the post-op refraction, the manifest refraction, again, same technique, refract to best corrected vision. Patient may be seeing 6.6, but when you do the refraction, there's the residue, you put it, he may improve to 6.4. Okay, so best corrected vision, residual refraction, and then you do your nomogram development. You can see what is the percentage. A simple percentage nomogram will take you to about 85-90%. Age related, all these other things can be added later, but a simple percentage nomogram where you look at how much undercorrection you're getting in terms of percentage or overcorrection, and then do the astigmatism separately for sphere and cylinder. That will actually, that is the first basic step. Then after that, you can look at multiple variables. You can look at age, you can look at the amount of myopia, you can look at your cap thickness. These are all variables which will probably give you
These
another 5 to 6% more improvement. But I would say like 90%, 85 to 90%
is
would be just a
refraction.
percentage nomogram. Yeah.
Also, post-operatively, you should not depend on your autoref. I think that is the mistake that everybody is
Yes.
doing. I had, in fact, one of the papers in which the person had done a study and he presented it in the form of autoref refraction,
Yes.
which
This was
would
on,
never be okay.
this
So
was on the silk, I think, and then he got pulled up quite badly, because this is something that, see, you should always use standardized techniques. You can't use an autoref. People are afraid of doing a manifest refraction, so they just
refracting,
do the
exactly,
after refractometer. But auto refractometer, especially after refractive surgery,
is not
is
going to give you
horribly
a good
inaccurate.
effect.
Horribly inaccurate. So it's something that's
Right.
not done.
My next question is, how do we determine the right timing for treatment following a
Retreatment.
overcorrection?
Okay, so basically you will have to wait for a minimum of 3 months. Because why 3 months? 3 months is the time that the epithelial healing stabilizes. So it can be anywhere from 3 to 6 months, but a minimum of 3 months is what you wait for, especially if you're looking at regression. Because early treatment, unless you have put in the wrong refraction. Suppose there is a transcription error. Say instead
Okay.
of putting
Yeah.
like -3, you have put in -2, and then you find that there is like a -1 post-op. Then you can go in and do a correction, because here it is an undercorrection because of wrong input. But otherwise, if you're looking at regression, then you have to wait for a minimum of 3 to 6 months, because it has to stabilize. The refraction, the epithelium has to heal, the refraction has to stabilize. Progression of myopia, you do serial axial lines, you wait, at least the refraction should be stable for 6 months to 1 year. And then once the refraction is stable, then you can do an enhancement. Otherwise, you do an enhancement and again there is a progression of myopia, again the patient has residual refraction, again it's a problem. In patients who have had residual refraction because of progression of myopia after pregnancy, you always ask them, when are you planning your next pregnancy? Because they may be planning after 2 years or so, and you do an enhancement, and again they have some amount of progression, and then you don't have any residual tissue to treat them. So you'll have to discuss with your patient and then decide the time for the enhancement.
Like you mentioned, sir, there are 4 machines now available. In retreatment, would you prefer using the same machine, or any cross-platform retreatment will have any advantage?
You can use any other platform. See, Visumax is the only platform that offers Circle software.
Right.
So if you want to do a hyperopic enhancement, okay, then you need a Circle software. You can't program a flap with the side cut and then do it, because then it'll be very small, like I explained. You'll have only like a 7 millimeter bed, which is not adequate for a hyperopic enhancement. So you have to use the Circle software. But if it's like a myopic enhancement that you're doing, then you can just program a side cut. If you have like a 120 cap or 110 cap, and do that. If you have a 135 and above cap, then you can do a thin flap LASIK on any platform, any femto platform. You can also use the SBK. If there's any scar or anything, then you can also use the SBK to get a thin 90 micron or 100 micron flap. But again, you should measure the cap thickness. So you can use, but you'll have to do a proper assessment. And like I said, epithelial maps are mandatory before retreatment, because they give you a lot of information. You can look at whether the regression is because of epithelial thickness. Sometimes you have early regression, after 1 month or 2 months only, the patient comes back saying that I'm not able to see clearly, and then you do an epithelial map and you see that there is an increase in the central epithelium. Then you can put these patients on steroids for 2 to 3 months, a low dose steroid like FML, and then you see that the epithelial thickness also reduces, and then their regression is not so much, and they kind of settle down. So these are all things that are very important. But what I advise is, if you are a refractive surgeon, then you should have access to epithelial thickness maps. You should incorporate it into your practice.
Also, Amit, you were talking about the timing. You should have at least what I follow is that 3 refractions, which are cycloplegic refraction, done at a gap of 1 month. If they are the same, then and then only I try and do a retreatment, not before that. And I also like them to have a better tear film, so I usually put them on cyclosporin eye drops for 3 months, so that at least it gives you a time for trial. So I generally tell them that we should try with the drops, and if that doesn't happen, we'll do a small touch-up. And that gives me a time to improve that tear secretion. And also, as Shri rightly pointed out, your epithelium becomes stable and your refraction becomes stable. So it's a better environment to go in and operate rather than just do it at the first sign of anything developing. And
That's very
manifestation
important.
after cycloplegia is important because sometimes it's accommodative spasm, and you have to be careful about that.
Ocular surface assessment is very important because many of these patients who have dry eye can have blurring of vision, and they can have shifts in refraction.
Yes.
Because the dryness also causes epithelial changes. Excessive dryness can cause thinning of the epithelium also. So they have a fluctuation in the refraction. So it's very important to treat the ocular surface and then do a proper refraction, and not more than 0.5 increase in the refraction between consecutive refractions, like Dr. Uppal said, because you can have 0.25 difference between people who refract, but anything more than 0.5, then you wait.
Right, sir. Thank you. Is there any difference in the expected visual recovery time in retreatments as compared to the primary KLeX procedure, or it's as immediate as
If you're doing a surface ablation, then the recovery time is more. It can be up to 2 to 3 months.
Yeah.
But if you're doing a thin flap LASIK or a circle, then recovery is immediate.
Great. Okay, Dr. Kritika, do we have any? I think we are way beyond our time, but do we have any questions from the audience?
Yes, sir, we have 2 questions. And the first question is, please elaborate on the cosine effect causing regression.
Okay. Cosine effect is also known as fluence projection loss. So it's called the summer-winter effect. So in summer, you can see that the sunlight is stronger. In winter, it's less because of the shape of the earth and how the sun rays are hitting the earth. So similarly with the cornea, which is convex in shape, with the excimer laser, when it's hitting the center, then the spots are round. So you have a concentration of the energy, there is no loss of the energy. But when it hits it sideways, okay, there's an elongation of the spot. The spot is not in complete focus. And because of this, there's a loss of energy. So the loss of energy prevents the exact amount of tissue removed per spot. So because of this, you will have lesser amount of tissue being removed in the periphery as compared to the center. This is the fluence projection loss. To compensate for this, in wavefront optimized LASIK, so what happens is, when you have the cosine effect, you have higher induced spherical aberration. So in older flying spot lasers, because of this cosine effect, where you had fluence projection loss, lesser tissue being removed in the periphery, you had higher induction of spherical aberration. So to counter this, they came up with a wavefront optimized treatment where they delivered extra spots in the periphery to compensate for this energy loss, so that the correct amount of tissue could be removed. And that is wavefront optimized tissue, wavefront optimized LASIK. And that's how basically you compensate. And that's why the spherical aberration profile is better with a wavefront optimized LASIK than with the regular standard LASIK. So this is the fluence projection loss, and that's why you get smaller zones in an excimer laser ablation when compared to a femtosecond lenticule extraction, because here it is the exact amount of tissue being excised. There is no loss of energy.
Okay, sir. And the second question that goes is, does coupling phenomenon lead to regression in a patient with high cylindrical error?
Yes. Again, coupling phenomenon is something that cannot be predicted very well, because what happens is once you flatten one meridian, okay, you're removing more tissue, flattening one meridian, you get steepening in the other meridian.
The
That's known
meridian.
as the coupling effect.
Yes.
And the coupling effect also depends upon corneal biomechanics, okay, which is different for different patients, different eyes. And also the epithelial changes and healing also can be different when you treat high astigmatism. So these are all factors, these are confounding factors which can affect your outcomes apart from cyclotorsion compensation. So if you don't have cyclotorsion compensation, most of the platforms don't have cyclotortion compensation. The only platforms probably that have cyclotortion compensation are the Smile Pro with the Vismax 800 now, which is
Centraline.
markerless
Yes, sir.
cyclotortion,
Yes, sir.
and the Schwind ATOS machine, which can have a cyclotortion. This is a markerless. Otherwise, you have to mark and then compensate. Otherwise, even this is a confounding. You can get undercorrection if you don't do a cyclotortion compensation. Coupling effect again does not give rise to so much of undercorrection, but you can have some amount of residual power. So even when we do excimer treatments for very high cylinders, pure cylinders, especially where you don't have spherical error, then the coupling effect can be there, and you have to warn patients that about 10% of them may need an enhancement. And so pure cylinders, you can also use Smile. You can treat pure cylinders, but with an excimer laser, it's easier to retreat. Otherwise, you have to use the circle software and then treat it. But we get excellent, if you have a proper nomogram, like we have a nomogram for cylinder, we actually get good results. And what I've found is that the long-term stability of cylinder
Yeah, the
correction
stability
is
is much
actually better.
better.
Better with Smile, with
Yes.
KLeX than with excimer
Yeah, that's
lasers.
been my experience also. The stability is much better.
Sir,
Great.
how long does this coupling effect take to settle? If it is happening in an eye, then how long does it take to settle? Like
3 to 6 months.
approximately.
3 to 6
Again.
months.
Okay, sir.
Okay, I think we are done with the questions, Dr. Kritika. And I would
Yes, sir. That's all, sir.
Okay.
That's all, sir.
And I would like to thank our chairperson, Rupal ma'am, and our speaker, Dr. Sri Ganesh sir, for sparing their very valuable time and sharing all their huge expert experience with us. I think all the listeners, not only students, but uh, seasoned ophthalmologists would also benefit from this lecture a lot. And thank you so much, sir. Thank you so much, ma'am. And thank you, Dr. Kritika, and the admin support team. Thank you so much.
Thank you, Amit, sir. Thank you, Sri Ganesh, sir, and Rupal, ma'am. Thank you so
Thanks,
much for the
Vicky.
class.
Thank you very much, and have a good night. Thank you.
Good
Good
night,
night,
sir.
sir.
Good night,
Good
ma'am. Good
night.
night, sir.